All right, so now we will do part 5 of our neonatal review questions. Question 26 gives us a 6-month-old female who presents with her parents. Mother says she was breastfeeding baby and suddenly the baby vomited a greenish color. Pregnancy, labor, and delivery in neonatal course were unremarkable. Stool is occult blood positive. Vitals are stable. Abdominal x-ray is ordered and reveals a double bubble sign with distal air fluid levels. Which of the following is the best next step in diagnosis? A. Upper GI contrast series. B. Abdominal sonography. C. CT abdomen. D. MRI abdomen. Or E. Anti-endomysial and anti-TDG antibody titers. All right, our answer here is A, upper GI contrast series. So this is a stable baby. Baby has a bilious vomiting, which is always going to be pathological. In this case, like I said, the baby is stable, but we also have a stool that's occult blood positive, and that is always a concern too. So when you have a baby with bilious vomiting coexisting with occult blood positive stool, it's a double concern. You want to get an abdominal x-ray anytime you have a baby with these conditions, provided that they're stable. You get that abdominal x-ray, it shows a double bubble sign, which typically we associate with duodenal atresia. However, with duodenal atresia, we typically are not going to see stool that is occult blood positive. So that gives us a different presumptive diagnosis. And in this case, we need to work this baby up for a possible malrotation, possibly with volvulus. And since this baby is stable, it does afford us some time. So malrotation in volvulus is an abnormal or incomplete rotation of the bowel during fetal development. The bowel is not in normal anatomic position, and we will see that when we do our upper GI contrast series. Usually when you do surgery, you'll note fibrotic bands that cover parts of the small intestine, and this is what puts you at risk for both for obstruction and also for a volvulus. 70 to 90% of all cases are diagnosed within the first year of life, as in this baby. Major complications include intestinal obstruction, that's due to those fibrotic LAD bands. Also midgut volvulus, and this is a volvulus involving the superior mesenteric artery. And all of this is due to the fact that you have an abnormal position of the bowel, as well as those LAD bands, which can also contribute to obstruction. The symptoms are going to be bilious vomiting, again because this is distal to the sphincter. You'll also have bloating, as you would in any obstruction, distension. This will then be followed by fever, nausea, vomiting, blood-streaked stools, as we saw here, although it was occult blood, or melena. And this is all due to the fact that you have a certain level of necrosis in the intestine. The hydration status may vary. For diagnosis, provided the patient is stable, which we did have in this case, the best initial diagnostic step is going to be an abdominal x-ray, which is going to show you a picture that's pretty similar to duodenal atresia. The difference is patients with duodenal atresia are not going to have any blood in their stool. This will show the double bubble sign as well as distal air fluid levels. This must be followed up with an upper GI contrast series and/or contrast enema, which are critical for diagnosis. So this is an example of malrotation. What you see in malrotation is you've got your stomach here, but note that all the bowel that you see is on the right side. And what you should normally see is a small bowel that crosses the midline. But it's all on the right side here, and this is a sign of malrotation. Now, just malrotation in and of itself can be asymptomatic. If you were to do an upper GI contrast series of this baby before any of these symptoms developed, you would have gotten the same thing here, just like this. Even though the baby didn't have any symptoms, she still had malrotation. So imaging and malrotation. If you have malrotation only, as we just saw, if the patient has intestinal obstruction but no midgut volvulus, then the common finding is to see dilated bowel and on the right side only. If you have malrotation and volvulus, then you'll also have symptoms typically, and then also the common finding of the corkscrew or beaked-like appearance with scant contrast distally, because in this case you have an obstruction. Question 27. A G1PO mother delivers a term baby girl weighing 7 pounds 5 ounces. Maternal history is significant for HIV infection for the past 3 years. It's well controlled on HART, which is highly active antiretroviral therapy, and she's taking zidovudine, emtricitabine, and nevirapine. Pregnancy, delivery, and neonatal course thus far have been uncomplicated. Which of the following should be part of the routine initial management of this infant? A CD4 count, B, HIV ELISA screening, C, zidovudine prophylaxis, D, trimethoprim sulfamethoxazole prophylaxis for PCP pneumonia, or E, chest radiograph. So routine initial management for a baby born to a mother with HIV. And the answer to this question is C, zidovudine prophylaxis. So baby is not going to have antibodies to HIV immediately, or there may be maternal antibodies, and so doing an HIV ELISA screening is really useless because it doesn't tell us if the baby has contracted HIV or not. So you'll want to save that test for later. It's not going to give you any useful information. CD4 count is really also not going to be useful because that CD4 count usually drops later on in the HIV infection. Zidovudine prophylaxis is what we want to do here because giving the baby zidovudine is going to reduce the risk of HIV, of vertical HIV infection. We don't need to worry because typically these babies will have a healthy immune system at least as far as not contracting PCP pneumonia, so we don't need to give any prophylaxis, and a chest radiograph is not indicated at this time. So some special consideration for HIV pregnancies, infants born to mothers with HIV. So all mothers are going to be screened for HIV as part of their routine prenatal care. HIV positive mothers should begin taking zidovudine no later than 14 weeks of gestation. That's regardless of their CD4 count. The zidovudine is taken to reduce the risk of transmission to the baby. So even if the mother is not taking HART, and a lot of people don't take antiretroviral therapy until later on in their HIV course, however, anecdotally, parenthetically, there has been some studies coming out saying that antiretroviral therapy should commence immediately after diagnosis of HIV, but that's just something that's came out recently. But regardless, even if the mother's not taking antiretroviral therapy, she should begin taking zidovudine no later than 14 weeks of gestation. She can then stop afterwards if she wants. Elective cesarean section may reduce the risk of transmission, but only if performed before rupture of membranes. Once rupture of membranes has happened, vaginal delivery would be the best way to go unless there's other indications for cesarean section. After the birth, the baby should be tested for HIV regardless of results. However, that is going to be done later on. That's going to be, so the baby will be tested later on after you've given zidovudine. Zidovudine should be given within 12 hours of birth, and that's going to be taken for 6 weeks. A baby should be retested for HIV at 2 months and 4 months. A negative HIV result at 4 months will reasonably exclude the diagnosis. If the mother was not on zidovudine during pregnancy, the baby should be started on a double or triple antiretroviral regimen. HIV is an absolute contraindication for breastfeeding, so be aware of that. There's not very many absolute contraindications for breastfeeding, but HIV is one of them. Question 28. A G3P1 mother delivers a term baby boy weighing 4 pounds 9 ounces. Maternal and prenatal care was not obtained during this pregnancy. While performing nursery examination, you note irritability, tremor, and a high-pitched cry. The nurse informs you of difficulty feeding, as well as 2 episodes of diarrhea and emesis overnight. In utero exposure to which of the following substances most likely caused this presentation? A, codeine, B, cocaine, C, marijuana, D, alcohol, or E, heroin. All right, the answer to this one is E, heroin. Now, it's always going to be important to know if the mother is taking any illicit drugs, and that's always a question that you want to ask during the prenatal course. However, there are not a lot of drugs that necessarily cause this presentation, and heroin is really the only one that you're going to run into that does. Now, all of these medications should be, well, codeine isn't always possible to avoid, I suppose, but particularly cocaine, marijuana, and alcohol. Cocaine and marijuana, of course, are illicit drugs. Alcohol is legal, but it should be, of course, avoided at all costs during pregnancy. But these are not going to cause this particular constellation. With cocaine, we're more concerned about the pregnancy course. Cocaine can cause a placental abruption, and so that can threaten the pregnancy, but typically after the baby is born, you're not going to see as many symptoms. You may see some lethargy, but you're not going to see this high-pitched cry and diarrhea and so forth. Marijuana generally doesn't result in any kind of neonatal syndrome. Alcohol can cause a constellation of features. However, it's not going to be this. You're going to see things like a flat philtrum. You can go on and later see cognitive defects as the baby gets older. But fetal alcohol syndrome does not present like this. Heroin is going to cause this classic neonatal abstinence syndrome, which is described here. So heroin opioids are will perhaps cause the most severe presentation clinically in the infant because of the significant withdrawal effects, and that's what's leading to the symptoms that we see here. Mothers who abuse heroin will have a baby who is low birth weight and small for gestational age in 50% of cases, as we also saw here. This baby was 4 pounds 9 ounces, but was also term. So this baby is not only low birth weight, but also small for gestational age as well. Withdrawal effects typically occur within 24 to 48 hours as that heroin level in the baby drops. Symptoms, any fetal abstinence syndrome symptoms can be present. However, what we would expect in heroin, in a heroin withdrawal in an adult, we would also see similar symptoms in the baby. So tremors and irritability are usually the most prominent. Hyperactivity, hypertonicity are often present, and then you can also see vomiting and diarrhea, which can be very problematic because it threatens the baby's fluid status. Workup is going to be a tox screen, so you can get that on meconium and urine. You'll get toxicology testing. Also consider a urine tox screen on the mother as well. BMP should be performed because we're concerned about fluid status. You should also get calcium, magnesium levels, and then a heel stick blood glucose. The workup for neonatal abstinence syndrome is going to be, as mentioned, meconium and urine toxicology testing. Get a urine tox screen on the mother as well. That'll help you make a more definitive diagnosis. Get your electrolytes, get a heel stick blood glucose. Also do a Finnegan scoring. That's done for neonatal abstinence syndrome. The nurse will perform that over an extended period of time. And an echocardiogram. In some cases of heroin exposure, you can have some congenital heart defects, so you want to be aware of that. The general management for neonatal abstinence syndrome, there's really no consensus agreement on the best therapy, and no single drug has been identified as optimally effective, so I don't expect you're going to get asked this on the test. However, for practice, morphine sulfate is often the initial drug of choice. And initially this is given in small amounts, so 0.05 milligrams per kilogram every 4 hours. can be given orally. You can also add phenobarbital if there's suspected or documented polysubstance abuse and if the infant doesn't improve on morphine alone. There's also some evidence that morphine or a combination of morphine and phenobarbital is more beneficial than phenobarbital alone. Remember here, there's no consensus, so all of this stuff is just stuff I've gotten from the literature. Paregoric is often administered if diarrhea is a significant problem, but I need to emphasize here this is presently an off-label use. Frequent monitoring, of course, is going to be important for these babies. They may be admitted to the NICU if they're sick enough, but sometimes they'll be in the general nursery. They'll need to be frequently monitored. There's something called the Finnegan scoring, which I didn't include here. I think I might have talked about it in the other lecture, on the drug exposure lecture. But Finnegan scoring is done to chart the baby's progress. Supportive measures should be given, of course, electrolytes and fluids, and then non-pharmacologic support to comfort the baby, swaddling, rocking, and minimal sensory or environmental stimuli. So a lot of times it helps to send these babies to the NICU where they can be in their own room, can make the room dark and quiet. Babies tend to do better in these cases. And of course, consultation of a neonatologist should be considered. I would say it should be done, period. Question 29. A G5P4 mother delivers a term baby girl weighing 10 pounds 4 ounces. APGARs were 8 and 10 at 1 and 5 minutes. Maternal history is significant for obesity. Pregnancy history is significant for gestation diabetes mellitus. Delivery was complicated by shoulder dystocia, necessitating McRoberts' maneuver to complete the vaginal delivery. Nursery exam reveals a healthy-appearing infant on gross examination. However, moral reflex is absent on the right side, and the right forearm is held in pronated extended position. Which of the following is the most likely cause of this presentation? A. Erb's palsy. B. Fracture of the right clavicle. C. Klumpke's palsy. D. Injury to the lower trunk of the brachial plexus. Or E. Fracture of the right distal humerus. All right, the answer to this one is Erb's palsy. So this is a classic presentation of Erb's palsy. You have the history, you have the complicated vaginal delivery with shoulder dystocia, and then you have the absent moral reflex with an arm that's held in the pronated extended position. So this is classic Erb's palsy. It is the more common, compared to Klumpke's palsy, the more common injury to the brachial plexus during birth. So the brachial plexus, don't memorize the anatomy here, for this at least, but Erb's palsy is an injury to the more superior roots of the brachial plexus. Klumpke's palsy is associated with an injury to the more inferior roots. So I think, yeah, so injury to the lower trunk of the brachial plexus, that would be Klumpke's palsy. So this is the upper roots of the brachial plexus, C5 and C6, and these control muscles of the upper arm, muscles of the hand, and so forth. Erb's palsy occurs with higher incidence among larger babies, which this baby was, and those delivered breech and or with shoulder dystocia. It affects the C5 and C6 nerve roots. The most common presentation is lack of shoulder motion on the affected side. Baby will hold the shoulder internally rotated, arm close, and wrist flexed. The moral reflex will be absent on the affected side, but the palmar grasp will be intact. Look for concomitant clavicular fracture. However, they do not always occur together. You can have Erb's palsy without a clavicular fracture. The diagnosis is clinical. Because C5 is affected, there may be phrenic nerve impact, and that can affect the diaphragm, in which case the baby can have respiratory distress. So if you have a baby with respiratory distress, obviously you're going to get a chest x-ray. It may be useful to get a chest x-ray anyway, but you don't necessarily have to get it if the baby's breathing fine. The treatment is limb immobilization for 1 week, followed by physical therapy. More complicated cases can be referred to pediatric or neurosurgery. Monitor oxygenation and provide supplementary oxygen if there's respiratory distress. So here's a baby with Erb's palsy on both sides. And here's an example of Erb's palsy versus Klumpke's palsy. Note that Klumpke's palsy more so affects the hand, whereas Erb's palsy is affecting the upper arm and shoulder. I guess it also affects the hand in as much as you have this waiter's tip hand too. And Erb's palsy is much more common than Klumpke's palsy as far as we're talking about birth injuries. Okay, last question. A student nurse calls you to the newborn nursery concerned about the baby's head. He says it's malformed. When you arrive, you note an otherwise normal baby and healthy appearing with symmetrical elongation of the occiput forming a cone-like shape. The elongated portion is soft to palpation and the enlargement crosses suture lines. The baby was born via uncomplicated spontaneous vaginal delivery. APGAR scores were 9 and 10 at 1 and 5 minutes. Which of the following is the most likely diagnosis? A. Cephalohematoma, B. Caput succedaneum, C. Subgaleal hemorrhage, D. Subdural hematoma, or E. Macrocephaly. Alright, so the answer here is Caput succedaneum. You should be very, very, very aware of what this is. The reason is because it is so tremendously common. You also want to be able to know how to differentiate Caput succedaneum from the cephalohematoma and the subgaleal hemorrhage. And that's important because cephalohematoma and subgaleal hemorrhage are really, I wouldn't say emergencies as much as they are things that need to be treated and addressed. On the other hand, Caput succedaneum is very benign and it goes away on its own. So subdural hematoma is not going to show any abnormality in head shape, although that would be a problem if it were present. And then macrocephaly should be symmetrical and all across the head rather than just the back of the head. But note otherwise that this baby is healthy appearing and that it was born via vaginal delivery, which is typically how Caput succedaneum happens because there's pressure on the baby's head causing the effusion, and then also that this crosses suture lines, which notes that this is slightly more superficial than these other processes. And then, of course, also note that this baby is otherwise healthy. So this is an example of Caput succedaneum. It's very soft to palpation, reflecting the superficial nature of the pathology, and then also note this cone head shape. And also, it crosses suture lines. I don't have a really good picture of that, but indeed it does cross suture lines because it's so superficial. So examine for abnormalities of the scalp and head. This is always part of your newborn exam in the nursery. Cephalohematoma is a swelling of the head that's within the suture lines, so it will not cross suture lines. And this represents a collection of blood between the skull bone and the periosteum. This needs to be observed closely, and it may be followed by jaundice because you have a collection of blood. As that collection of blood gets reabsorbed, it breaks down, and so you can have jaundice. There may be an underlying linear skull fracture, so it could be useful to get a CT or an X-ray. Important thing to do is never aspirate the blood. This is a common wrong answer on the USMLE. You will not be sticking anything in that head to aspirate it. You can cause serious problems if you do that. For the most part, this blood will reabsorb. Caput succedaneum we just talked about. It's a cone head. This is seen as swelling of the head that crosses suture lines. It's superficial to the periosteum between the subgaleal aponeurosis and the scalp. And this will go away within a few days without management. This is very common. Subgaleal hemorrhage is really the biggest emergency out of all three of these. This can potentially be a massive bleed. It's often noted as fluctuant, boggy mass with some bruising that's superficial to the mass. It can obscure the suture lines, and it is highly associated with a vacuum-assisted delivery. So look for that in the history. You need to monitor for hypotension and tachycardia because this can be such a massive bleed. Remember that babies don't have a whole lot of blood volume to begin with. So it doesn't take much blood to get out of the circulation to cause hypotension and the tachycardia that comes with it. So you should monitor these babies both for hypotension and tachycardia, and also monitor the size of their subgaleal hemorrhage. This should shrink with time. If you need to, perfuse them with fluids and blood products if necessary. So this is a nice sort of comparison chart that I found online. Really doesn't give you a whole lot more information than I provided in the lecture that I talked about on this. But you can see that there are synonyms for this. Don't worry about those. Just know cephalohematoma, subgaleal hematoma, and caput succedaneum. So cephalohematoma does not cross suture lines, but subgaleal hematoma and caput succedaneum do. Then also remember the possible causes. So cephalohematoma is more associated with forceps delivery. Subgaleal hematoma more associated with vacuum extraction. Usually with caput succedaneum, you're going to see it in vaginal delivery. Clinically, the caput succedaneum is a soft pitting lesion. The subgaleal hematoma is fluctuant and firm. And also, I would add to that you can see some redness and bruising over the mass. As far as resolution, the caput succedaneum goes away within days. The cephalohematoma and subgaleal hematoma will take a little bit longer. So risk factors include, for cephalohematoma and subgaleal hematoma, include large for date babies, breech lie, and instrumental delivery. Some of the complicating factors include anemia, hypotension, hyperbilirubinemia, also infections. And if they don't resolve, then you should think about a bleeding disorder, because what that would indicate is that you're having continual bleeding into this injured space.